According to the Rome 4 criteria, the diagnosis of constipation must include more than or equal to two of the following: straining, lumpy or hard stools, feeling of incomplete evacuation, a sense of block, manual maneuvers like digital evacuation, and less than 3 spontaneous bowel movements per week. And all of these should be present in more than 25% of defecations. Number two, loose stools are rare except with laxatives. And number three, insufficient criteria should be present for the diagnosis of IBS. Symptoms must be present in the last 3 months and the start of the symptoms at least 6 months prior. There are 3 types of constipation: slow transit, normal transit, and a rectal evacuation disorder. Slow transit constipation is when there are less than 1 stool per week, poor urge, there is a poor response to fiber and laxatives, and it's more seen in women. In a colon transit study, you would find more than 20% of retention after 5 days. Normal transit would also have feeling of incomplete evacuation and plus or minus pain. Rectal evacuation disorder, they have frequent straining. FICE is a very predominant symptom, and they do use manual maneuvers 60 to 70% of the time, and there is an abnormal balloon expulsion. The risk factors for constipation are females more than males, especially the luteal phase in which the colon transit is delayed, and during pregnancy. This is said to be due to the overexpression of progesterone receptors on the colon smooth muscle. Age: older age people and children less than 4 years. In small children, they usually present with fecal retention and soiling. Ethnicity: Australia has the highest prevalence of 16% and Japan the lowest of 7%. Socioeconomic status: lower socioeconomic groups have more constipation. Diet and physical activity. Medication: acetaminophen more than 3.5 grams per week, aspirin, NSAIDs, tricyclic antidepressants, opioids, antihistamines, aluminium antacids, antiepileptics, calcium, iron, diuretics, all these can cause constipation. Endocrine and metabolic disorders: hypothyroidism, diabetes, high calcium, lead, low potassium, porphyria, pregnancy, and Addison's disease. Neurological and myopathic problems like Parkinson's disease, autonomic neuropathy, spinal cord injury, stroke, and amyloidosis. And of course, mechanical obstruction like in colorectal carcinoma, anal stenosis, rectocele, and stricture. Ingestion of bran is supposed to reduce colon transit by 1/3, and the prescription is usually 10 grams twice a day. The mean colon transit is usually 34 to 35 hours. Colon propulsions of 2 types. There is low amplitude and high amplitude. It's called LAPC, low amplitude propagated contraction, and high amplitude propagated contraction. There are interstitial cells of Carl, CAJAL, which is the intestinal pacemaker, and this initiates the slow waves throughout the GIT. And this is reduced in number in a slow transit constipation. Defecatory function. There is a pre-defecatory period in which there is increased frequency and amplitude of propagating waves, and this pre-defecatory period is also blunted in slow transit constipation. And the second phase is the defecation phase, in which the urge is there, and when stool is in contact with receptors in the anal canal, there is a push out. Squatting helps by straightening the anorectal angle. Colon inertia is an extreme state in which the disorder in which symptoms of constipation are severe and there is no colon activity despite a meal, giving bisocordyl, or even neostigmine. To defecate, the mechanisms involved are: first, the pelvic floor has to descend. Then relaxation of the puborectalis sling. straightening of the anorectal angle, and relaxation of the internal anal sphincter. Defecatory disorders. This is also called anismus, dyssynergia, or spastic pelvic floor syndrome or outlet obstruction. They commonly have inappropriate contraction of the anal sphincter when they bear down. They can't raise the intrarectal pressure in order to evacuate. There's a failure of pelvic floor to descend on straining. It's usually seen in older adults with chronic constipation, but can also be secondary to a rectocele, rectal intussusception, a megarectum, and excess perineal descent. The Rome 4 criteria for functional defecation disorder. First of all, it should be in the past 3 months with symptoms started 6 months prior, and it should satisfy the criteria for a functional constipation or IBS constipation. And during repeated attempts to defecate, features of impaired evacuation are shown by two at least of the following. One is an abnormal balloon expulsion test, two, abnormal evacuation pattern on an EMG or an ARM, and three, impaired rectal evacuation on imaging. A rectocele. When the perineal body is weak, the perineal body supports the anterior rectal wall. It's a collection of the fascia that's the rectovesical fascia. Rectovaginal fascia. This is in women. And in childbirth, there is a weakening of this fascia, and also in previous hysterectomy. Anterior rectal wall bulges above the perineal body. The clinical features would be local pressure, FICE, a bulge at the vaginal opening on straining, and the diagnosis is made by MR defecography or a barium defecography. The treatment would be Kegel exercises to strengthen the pelvic floor, surgery only if contrast retained during a defecography, plus symptom relief should be present by digital vaginal pressure. Then only proceed with the surgery. And the surgery would be either endorectal or transvaginal or transperineal route. The benefits of surgery are seen in 75%. Descending perineum syndrome. The pelvic floor descends to more than normal, which is more than 4 centimeters, when the patient strains during defecation, and rectal expulsion is difficult. This also is associated with a weak perineal body, a decreased anorectal angle, and the common reason is stretching during labor. Electrophysiological study shows damage to the pudendal nerve, partial denervation of skeletal muscle. And the clinical feature would be FICE, straining, and the use of digital maneuvers. Decreased rectal sensation. There's a poor urge to defecate, though the rectum is loaded. This is called rectal hyposensitivity, that is the insensitivity of the rectum to balloon distension on an ARM. It can be due to past anal surgery, pelvic surgery, spinal trauma. Rectal prolapse. This is the complete protrusion of the rectum through the anus. Occult rectal prolapse is seen in 30% of patients with a rectocele, and on a PR examination, the rectum is seen on straining. The treatment would be a laparoscopic rectopexy. This can be associated with solitary rectal ulcer syndrome, which is erythema or ulceration of usually the anterior rectal wall due to chronic straining. The patient presents with blood and mucus per rectum. Endoscopically, you can see erythema, hyperemia, an ulcer, and sometimes even a polyp, so that people have mistaken this for a hyperplastic polyp or the other types of polyp. And it can also be mistaken for carcinoma or ulcerative colitis because it can present just with an ulcer. On histological examination, you find the extension of muscularis mucosa between the crypts, and there's a disorganized muscularis propria. Other investigations to do are transrectal ultrasound, ARM, and a defecography. We suggest that the patient does not strain, does not sit on the potty for more than 5 minutes. Use of laxatives is definitely recommended. And you can do an argon plasma coagulation if the patient bleeds. Rectal prolapse and SRUS are part of the same spectrum and they can present together. The algorithm for constipation. So patient presents with constipation. First you rule out medication and secondary causes. Then you increase their fiber in the diet. 20 to 30 grams per day is recommended. Laxatives, lubiprostone, linaclotide are tried, and if there is an inadequate response, then you do an ARM or a balloon expulsion test and a balloon expulsion test. And if these are abnormal, straight away go in for biofeedback, or sometimes you might need to repair a rectal seal or a rectal prolapse. If it is normal, if the ARM balloon expulsion test is normal, we can proceed to do a colon transit study. And if that shows a normal transit, we diagnose normal transit constipation. If it is slow transit constipation. For slow transit, we give them laxatives like osmotic laxatives, stimulant laxatives, and prokinetics. But the last option, if he does not respond at all, would be a colectomy. And there are various other surgical options. If the colon transit study is normal, it's normal transit constipation, we treat them like IBS. If the ARM and balloon expulsion tests are inconclusive, we do a barium or an MR defecography. If that is normal, we proceed to do a colon transit study. If it's abnormal, go ahead and do a biofeedback. The diagnosis and treatment of defecatory disorders. The ability to coordinate abdominal, rectoanal, and pelvic floor muscles to facilitate defecation is gone. And hence there is 1, an inadequate propulsion, 2, a paradoxical contraction of the anus instead of a relaxation, and 3, there is inadequate anal relaxation. The clinical feature would be straining in 85%, FICE in 75%, Digivac in 65%. They could have anal pain, sense of bloating. The diagnosis, first you rule out other pathology, assess the colon as slow transit constipation can coexist in 2/3. You assess the distal colon, rule out any structural abnormality like an anal stenosis. And then you do a digital rectal examination and you ask, is the patient able to feel stool if stool is present inside? And if there is rectal hyposensitivity, you can diagnose it that way. Assess the resting tone, whether it is a high resting tone or a loose resting tone of the sphincter and the puborectalis. Then you ask the patient to bear down and see, is the sphincter relaxing? How much is the pelvic descent? And you place the hand on the abdomen to feel if the patient is having good effort. Then the ARM, anorectal manometry. You can assess adequate propulsive force, in which there is increased intrarectal pressure, more than 40 is normal. Then you can assess if there's inadequate anal sphincter relaxation. If less than 20%, it's abnormal. It's less than 20% is normal. If it's still high, it doesn't relax, then it is dyssynergia. Proceeding to the ARM and how to read it. The one on top is the normal one, which the pressure of the rectum goes up during the defecation and the pressure inside the anus goes down. But in type 1 dyssynergia, both go up. The rectal pressure is high, anal sphincter pressure is high. So it's a paradoxical anal contraction. But the rectal push is normal, it's good. In type 2, the rectal push is low and there is a paradoxical anal contraction instead of a relaxation. Type 3 dyssynergia, there is inadequate rectal push and absent anal relaxation. In type 4, both are low, so there's a decreased rectal push and there's absent anal relaxation. Balloon expulsion test. There's a 4 centimeter balloon with 50 ml of water. It's placed in the rectum, and the normal expulsion time should be less than 60 seconds. In older people, the time is actually less than 60 seconds, much less, about 15 to 30 seconds. The specificity of this test is 80 to 90%, but the sensitivity is very low, it's only 50%. MR difficography. There's a straining phase, and this gives you information about the competency of the internal and external sphincters. The squeezing phase, in which the pelvic floor muscle strength is what is tested, and the defecation phase to see any coordination or incoordination. The inability to evacuate 50% indicates a defecatory disorder. In this ARM, we see type 1 on the left, dyssynergia in which there is no anal relaxation and there is normal rectal push. Type 2 is on the right on top, which shows this is not green on top, so the rectal push is less, pressure is less. But the anal pressure is going up. That's 2. Type 3, both are less, but not completely gone. So there is some, but a partial push pressure in the rectum, but there is no pressure inside. It doesn't relax. The anal sphincter doesn't relax. And both are absent in type 4. This helps to diagnose, what helps to diagnose? It's the MR difficography that helps to diagnose rectocele, enterocele, rectal intersusception, descending perineum syndrome, and spastic pelvic floor syndrome. The treatment of constipation begins with good fiber, laxatives, timed toilet training, and biofeedback. This is for dyssynergic defecation. Classification of laxatives. There is osmotic laxatives, stimulant laxatives, stool softeners, calcium channel activators, guanylate cyclase activators, and 5-HT4 agonists. The osmotic laxatives include poorly absorbed ions and poorly absorbed sugars. The poorly absorbed ions are magnesium containing ones, which are magsulf and magnesium hydroxide. The sulfates, example sodium sulfate, and the phosphates. The phosphates, if we give oral phosphates or even rectal phosphates, there's a high chance for hyperphosphatemia in children and in patients with CKD. Then you have the poorly absorbed sugars, which is also osmotic laxatives. There are disaccharides like lactulose. The problem with lactulose is that it's unpredictable and can cause bloating. The mechanism of action is the lactulose reaches the colon, and the bacteria act on it to form short-chain fatty acids. And that's one of the side effects. That's why there is more bloating. Sugar alcohols, there are sorbitol and mannitol, and PEG, which is polyethylene glycol, is useful for colonoscopy preparation, and it's also useful for fecal impaction. And it has a good effect on colon transit. There is less bloating associated with PEG. But the side effects could be allergy, electrolyte imbalance, and if it's given by the NG in large volume, it has resulted in pulmonary edema as well. Stimulant laxatives include anthraquinones like senna, ricinoleic acid, which is castor oil, diphenyl methane derivatives like bisacodyl and sodium picosulfate. Stimulant laxatives increase intestinal motility, they increase water and electrolyte secretion into the lumen, and they increase colon transit. They hasten it. If there is a prolonged use, it has resulted in a cathartic colon, in which the colon isn't moving, and a condition called pseudomelanosis coli, in which there's pigmentation of the colonic mucosa. Stool softeners, so docusate sodium, chloride channel activators, which are lubiprostone, given at a dose of 8 to 24 micrograms BD, guanylate cyclase activator, which is linaclotide and plicanatide, and 5-HT4 agonist, which is prucalopride. Linaclotide is a guanylate cyclase C receptor activator. It increases the CGMP and therefore increases the secretion of chloride and bicarbonate into the lumen, and thereby stimulating contractility. In phase 3 studies, the percentage of people with more than 3 spontaneous bowel movements per week was more. There was increased stool frequency, it improved the consistency of the stool, and there was decreased straining. But the most common side effect was diarrhea, especially it was seen in 30%. And 4% of the patients in the trial actually discontinued it because of the diarrhea. It cannot be given in children less than 2 years. 5-HT4 antagonists are serotonergic laxatives. They increase intestinal motility. There is cisapride, tigacerod, and prucalopride. Cisapride is actually taken off the market because of fatal arrhythmias. Tigacerod has also not been used in patients who are prone to cardiac abnormalities, but it has been approved for women less than 65 with no history of heart disease or stroke. Prucalopride is given at a dose of 1 to 2 milligrams OD, and this has no cardiac side effects. Ileal bile acid transporter inhibitor, ilobixibat. This inhibits bile acid transport into the terminal ileum. Therefore, there is more bile acid reaching the colon. And this acts as an osmotic laxative, increases the water and electrolyte secretion into the colon, and stimulates a peristalsis. This softens the stools and there is a faster transit. The dose is 5 to 10 milligrams a day. Cholinergic agents, IV neostigmine. This can be used for acute colonic pseudoobstruction. Pyridostigmine has been given in diabetics with constipation. It accelerates colon transit, but it's not effective in gastric emptying or in small intestine transit. Vibrating capsule is a mechanical, it's a little device which stimulates the bowel wall, which simulates the bowel wall contractions. So it increases the circadian rhythm of the colonic activity. It causes 2 vibration cycles over 1 day and at 3 hertz, and each of these vibrations happen over 2 hours. There is a slight increase in spontaneous bowel movement compared to placebo, 39 versus 22%, but we don't really know whether this is statistically significant. Biofeedback, 60% success rate in dyssynergia. It's used to train people to relax their pelvic floor during the act of defecation. So they give a simulation with either a balloon or a silicone-filled artificial stool, and there are 6 sessions in 6 weeks. Surgeries for constipation include colectomy, which could be partial or total, with a response rate varying from 39 to 100%. 2, they can construct a stoma. Initially, colostomy is constructed, but if the patient does not respond, they can do an ileostomy. Problems with this is the patient can have small bowel diarrhea. Surgery for defecatory disorder includes STAR surgery, which is stapled transanal rectal resection, especially if a rectocele or an intussusception is present.